To the supporters of Selalelo, my name is Lentlametse, the coordinator for this program sponsored by MORE, the Movement in Omaha for Racial Equity. Today, I have a very special guest. His name is Lentlametse Mantshonyane, and I'll leave it to him to introduce himself better.
Hello and good morning, dear listeners. My name is Lentlametse Mantshonyane. I am a Botswana. I come from Botswana because I lived in Kumaga. So the place I really call home is not really Maung, it's Kumaga. Kumaga is in Boteti West, just after Reikops. It's a small village with a large character.
Okay.
Yeah. In terms of growing up, that's where I grew up. I went through the normal government systems, humble beginnings. I studied nursing for my undergraduate, so I had a bachelor's degree in nursing. And then I practiced in the Botswana healthcare systems. And then I left. I went to UPenn to study clinical epidemiology. And then I came back to Botswana, and because of issues, I ended up leaving the government, and I joined UPenn as a researcher, associate researcher. So I've been doing health research for the past 5 years. And then I left in 2022 to come and pursue my PhD in genomics, epidemiology, and biostatistics. So now I'm here at Case Western Reserve University in the US pursuing my PhD.
Excellent. You don't get to hear a lot of Botswana researchers in the medical field, and that's why I really wanted us to talk. Well, this program is called Selalelo. As you know, Selalelo basically means supper or dinner. And what we do here, we usually have guests and we share a meal, and then we discuss topics that are of interest. Things that we like talking about on Selalelo are issues surrounding regional integration of African countries. Ultimately, the issue is to talk about African unity, which we know is very elusive. We've never been able to attain it. And we talk to different people to try and see from their perspectives what the problems may be, because we don't understand why our governments are not doing anything or not doing enough to bring Africans together. And we just don't want to bring Africans together just for fun. There's a big problem of global racism, and we know that if Black people pull together, there's a chance that they may be able to stand up to racism as a united bloc. So now, today we're going to talk about something that is totally different from what we normally discuss, but it is very, very key because we know that Botswana, like most Southern African countries, are still hit hard by the HIV pandemic. And we also have a problem with, is it a pandemic? What is HIV? What is the status of it?
It's still a pandemic.
Yeah. And, there's been the aid that we've been receiving for HIV AIDS help has been pretty much, has it been cut or has it completely disappeared? Whatever the situation.
Yeah, I mean, it's been affected. Mostly it's been affected. It's literally they've just suspended it for some time. But I understand in Developili and other areas, some of the PEPFAR-funded programs in Botswana, they've still continued to benefit from that, but not all of them. So some of them have been affected and not all of them.
Yeah. So HIV is a major, major problem for Southern Africa. And I just want the listeners to know that, you did this study research on universal testing and treating of HIV positive persons. So can you just tell us what motivated you, for instance, to do that study and explain what this universal test and treat means in simple terms for people like me who are not clinically inclined.
Like I mentioned in my introduction that I have a Bachelor of Science in Nursing degree, and then I worked for the government. So that means I was working in the public sector in Botswana. I was based in clinics, and one of the programs that I was spearheading was HIV management. So I was basically treating HIV patients. And I was responsible for so many ARV clinics in the country. And as someone who's responsible for that program that runs HIV became something that was really interesting to me. And that's what motivated me. So what had happened is initially in the earlier iterations of these HIV treatments, what we would do is we would someone would test for HIV and then would monitor them for some time, trying to see whether they have declined, their immune system has deteriorated to a point where they actually need treatment before we actually started them on treatment. So during this monitoring, people were dying. Some people were dying waiting for treatment. And it was not just because it's medical to do that. It's just because the resources were not really there. So we needed to prioritize and give resources to people who really needed these ARV resources. And we didn't have much of it, even though we're relying on donors and international partners. So we had to rationalize and try to give them to people who really need them. As you know, HIV is a chronic illness. So you're not going to contract HIV today and die tomorrow or next week, or it may take years and years for the disease to manifest. So that has been the treatment protocol. So we'd monitor them and then screen them, see if they develop any diseases that suggest that their immune system has been compromised, and then we will start them on treatment. And we had set certain levels of cut-ups. And then I think in 2012, we changed and then we increased the threshold for the CD4 count monitoring. So we increased the threshold from around 200 to 350. So if you are monitoring a patient and then their CD4 level, which shows their degree of immune destruction, to that person drops to 200 350, then they will qualify to be started on treatment. So that was much better compared to 200, because at 200 we're losing people because, as you know, people are different. For someone, it may take a CD4 decline of up to maybe 150 or 200 before they start showing symptoms of actual disease. But for other people, it may only take like a 10% decline in CD4 count. Some people were developing WHO staged condition, even with CD4 counts that were greater than 200. So they were really showing some illnesses and symptoms of illness. And so by the time they reached, some of them didn't even reach 200, but by the time they reached 200, some of them are already dead. So we're losing patients. So we increased the threshold, and we're able to save a lot more people, but it was still not enough. And then shortly after that, there were a few studies. There were like 2 studies. I remember Tempran was one of the studies that were done, and they started to show that actually, if you start patients on treatment as soon after they get tested, you tend to prevent more deaths. They tend to do much better. They don't develop these opportunistic infections, and the general well-being is much, much better. So starting treatment immediately after testing HIV positive was something that was seen as a good operational strategy. So the WHO issued advisory to say people should now be tested and treated immediately after they have tested positive. And different countries, as you know, WHO just issues advisory scientific expertise, and then different countries adopt from the WHO to suit their local needs. So in 2016, the Botswana government made a bold decision to say, okay, we are going to now test and treat. So if we test you for HIV and you test positive, we are no longer going to be waiting for these other things, this monitoring process, this long monitoring process and tedious process of over the years. You test today, our plan is to start you on treatment. So if you just start treatment...
That same day, you mean?
Yeah. Okay. If you are ready, we test today. You are ready, we start you tomorrow.
Okay.
But according to the guidelines, up to seven days is still considered a rapid test.
Yeah.
So it was at that point in 2016, June of 2016, that this decision was taken, and it was implemented. It was rolled out around the country. And I was still there, and I was seeing this program being rolled out. And as a scientist, I was also wondering, is this going to is this going to really be beneficial for a local setting, or is it a policy that is not, it's just being started on an emergency basis, and we have not really considered other issues that may
Or
emanate
maybe
from
being
it?
coerced by the international community.
Or maybe being coerced by international partners who
Yeah.
are supporting us in our HIV care rollout.
Mm, mm.
So I had those concerns as a citizen, especially because, while we were monitoring with the previous strategy where we were waiting for people to reach 350, it means so many people, we were also doing driving HIV testing. So many people were testing for HIV.
Mm.
And as they come early, their CD4 count is still high. It means there's a backlog of patients
Yeah. Mm,
who are waiting to
mm,
be started on treatment. They keep coming to the clinic every 3 months to get their samples and then get their CD4 cell counts read. And then they get told, okay, come tomorrow, okay, come next month, or come in 2 months, 3 months, 6 months. So this backlog was building up. So by the time they announced this, it means we had more patients who were now qualifying because they had been waiting. So,
yeah. Yeah. Yeah.
so as you can imagine, that I anticipated that was going to cause potentially going to cause a lot of strain to the healthcare system. And I was wondering whether the healthcare system will be able to cope with this other additional pressure that is coming in.
Was it able to?
Well, that's a good question.
Mm.
Well, that's a good question. So it seems like the healthcare system in Botswana was able to handle the pressure.
Okay.
It was able to handle the pressure. And the reason I say that is because if you look in the study, actually the title of the study, it says universal test and treat.
Yeah.
It didn't bring much change, didn't have much effect
Mm.
in the Botswana healthcare system.
Yeah.
So even though it
Did
was a
that
good
surprise you?
intervention.
Did the fact that it didn't really affect?
It actually did. It
Uh-huh.
actually,
What were you hoping
it
to
actually
find?
did because
Yeah.
being in the system, I was confronting these problems head on, and I was there, and I was just wondering, is this really working? I didn't know that we were actually achieving our goals before I started this study.
Mm.
But of course, I would hear from reports that, Botswana is achieving, 80, it started at 80, 80, triple 80, and then 95, 95, 9, triple 95
What is that? I actually
goals.
saw that a lot, and I was like, yeah, I need you to explain that.
Okay.
Yeah.
Okay, let me explain this. So,
Yeah.
so that's a really good one. So we need to explain that. So like I was saying, WHO sets the strategy, right?
Hmm.
And says for us to be able to reach our complete objective of eliminating HIV,
Mm.
the main important thing, and I think this is a scientific fact that was realized much later, that for you to prevent HIV, you actually have to treat HIV.
Mm.
So once you treat HIV, you will prevent new infections once people take treatment. But that is not just a blanket statement.
Mm.
It means that you should reach people who are HIV positive and may not know that they are HIV positive. So the first 90 is like you have to test 95% of
Mm.
people who, yeah. So 95% of people should know their HIV status.
Mm.
So that's an objective that
Mm.
it's a target that you have to achieve.
Okay.
And then of that 95% that you've tested, those that tested positive, that means they need treatment. So those need to be treated. So
Mm.
95% of those have to be put on treatment.
Okay.
And then the last 95 is for those who are put on treatment, 95% of them have to achieve virologic suppression.
Oh,
So they
okay.
have to suppress their viral loads.
Yeah. Yeah. I
So
get it.
once your viral loads is suppressed, we have scientific studies have proved that you cannot transmit HIV to the next person if your viral load is suppressed.
Mm.
That's where the concept of U equals U comes from.
Mm.
So if you are suppressed, you cannot transmit HIV.
Okay.
Yeah,
No,
so
that's
that's the
actually a
triple
very smart
95.
thing.
That was it was. Yeah,
Mm.
it was. Yeah, so back to the question, this thing really surprised me. But we were able to learn from it is because, Botswana had been doing well even before the introduction of test and treat in 2016.
Mm.
So it means this introduction of a new strategy didn't really change much in
Mm.
terms of achieving those specific patient level goals. Yeah.
So let me take you back since you were in the mix of things when the HIV crisis started. So,
Mhm.
what was the critical time where it was suddenly discovered that, the system is overburdened with this illness? When was because I was away for a little while myself, 30 years ago, and I remember around about
Mhm.
late 90s, 1997, 8, 9, when there were a lot of deaths. Was that like the moment where things just like blew up, or when was it?
No, no, it was much, much late. Like,
Mm.
because our HIV treatment program in Botswana, including PMTCT, started in 2002.
Mm. Mhm.
Yeah, so we started to roll out these things in 2002. And when we started, these treatment centers were only in Gaborone.
Mm.
you
Wow.
know. And then a few years later, about a year later, they rolled out to Francistown, and then they ended up opening another site in Maung. So for some time, we had only 3 treatment centers in the country, and you can imagine, and
Yeah, that was
HIV was
that was
just
crazy.
widely spread. So you had people who were HIV positive and they couldn't access these treatments because, the facilities were not there. Even if they had tested positive and even if they get referred to these facilities, we didn't have enough adequate staffing that were well trained to manage patients like this.
Mm.
So you would have only maybe in Marina, you would have 1 or 2 doctors that were trained to treat HIV. And so you will have 2 nurses that were trained to, counsel patients before they get to start treatment. So all of these processes, they delayed people from starting treatment and actually start getting the care that they needed.
Mm.
So the government had to train nurses, they had to train more doctors, and then equip them with the skills to be able to treat HIV. I was one of the cohort much, much later that also benefited from the same training. So
So
went
now
for
is
training
it
for like
standard,
6 weeks.
is it part of the standard training now to deal with HIV?
Now, yeah, now they actually have a program that runs it in the Ministry of Health.
Mm.
But initially, Harvard, colleges like Harvard, they were conducting the training in partnership with the ministries, and
Mm.
then Baylor College also joined.
Yeah.
Botswana UPenn also joined in,
Mm.
and then they were conducting these trainings. The point was capacity building. So they trained the trainers, and I was one of the trainers. And then we started going around the country training more nurses. And then there was certification for nurse prescribers. So now you have nurses who were skilled now, trained, well trained. They could prescribe ARVs to patients.
Mm.
That was alleviating the burden for doctors. So when you have patients and the population of nurses is much, much higher than that of medical doctors in
Yeah.
Botswana.
They are
So
basically the doctors of our
they
village.
are the doctors, they are our doctors in Botswana. Nurses
Yeah.
are our doctors. They are like the backbone of our healthcare system.
Yeah.
So, yeah, so
So
that's what happened. So there had been some work that was being done leading up to 2016, and it was just learning from these problems that we were having.
mm. So
Yeah.
in your paper, you
Mm.
talked a lot about the problem of people who miss their clinic appointments.
Yeah.
So what happens at those clinics or at those appointments? Is it where they draw the blood and everything?
Yeah, no. So this is what happens when you start a patient on antiretroviral therapy, which is the medication that is used to treat HIV.
Yeah.
You have to monitor them, and the reason for monitoring patients is because these drugs may cause some toxicities.
Mhm.
You know, yeah, they are drugs, so they may develop some toxicities or side effects,
Mhm.
and you want to make sure that these patients are actually taking their treatments.
Mhm.
So adherence is a very important aspect in HIV care because HIV does not forgive you for non-adherence. If you take your treatment and not take it well, it will develop resistance and the drugs will stop working. So you'll need another set of drugs. And we don't have many options.
So
So we monitor patients like that. So we'll see them and then we'll have a panel of tests that we'll order. Maybe come back after 3 months, do these tests. And then that's when we'll issue you another batch of prescriptions for drugs. But what we are seeing now is people who have been on treatment for some time, eventually they just stop showing up or honoring those appointments. And
so
now when they don't honor the appointments, ideally the healthcare system has to follow up, phone them, trace them, try to see what happened, where are they. And sometimes they succeed, but a lot of times they don't succeed in following those
why do you think
patients.
people stop coming?
There are many reasons. One of them is that patients may die and not notify the healthcare facility that they have died. Patients may move from one town to the other. We are very mobile people in Botswana. Someone living in Maun today, 2 months down the line, they be moving to Gaborone or Selebi Pikwe to live there. And in your records, you only have the address for Maung and you don't have the address for Selebi Pikwe, so you can't trace them even if you call them. The other thing is that people get tired because this is lifelong treatment. And it's tiresome. This pill burden, pill fatigue it's a thing. It's a real thing. So people just experience pill fatigue and they stop taking their treatment. Or it's people who have not really accepted that they have HIV. They're still in denial. And therefore, they may have started treatment under pressure to start treatment, but deep down, they didn't really want to start treatment and they were not ready. So they stopped taking treatment and stopped honoring any appointments.
I think others have been told that they've been healed by
religiosity is also another thing. There are churches that have been sprawling around, and I can't tell you how many cases I've handled of patients that stopped treatment because they were told by their pastor that they are cured at church.
I know about that.
Yeah. So it's a whole host of reasons, and there are many reasons. Every patient is as unique as you can think, and they come with so many other reasons why they've decided to stop their treatment. But the other thing that I've also found is that patients can move to a different facility without notifying their primary facility. And they get there, they go through the same process, they get tested. And then they get put on treatment as new patients, but they are not actually new. They were already started treatment 2 years ago.
But isn't the system centralized where,
Now it is. It didn't always used to be. It didn't always used to be because now you have to catch them with their ID. So you enter the ID number, then it will reflect in the system that this is not a new patient. Then okay, this patient just started treatment somewhere else, but it wasn't always like that.
So now let's talk a little bit about healthcare workers. So what do you think can be done, to support them so that they can continue helping people better? Because I think this, that we the citizens are a little unhappy with how we are treated in government hospitals and clinics. What do you think needs to happen?
I think the attitudes of healthcare workers are a reflection of how healthcare workers are being treated. Healthcare workers, you have to understand that healthcare workers are people who take an oath to come and help their communities. But they do so using the skills that they have acquired. They are not volunteers.
They're not Florence Nightingales.
They are not. These things have changed. I've often heard people saying professions like medicine, nursing, those are a calling. It's a calling if you get rewarded for the job that you are doing. People do this as a source of livelihoods, and then when they knock off at 4:30, they are on call. So they can't go anywhere. When you are on call, you cannot go anywhere. You have to be within reach of the facility because you are waiting for emergencies. Unfortunately, while you are waiting for emergencies, life goes on. and you are not rewarded for waiting.
Lent,
That time they are not paid
why
for
can't
it.
we train many more nurses?
Yeah, that's the thing. The schools of nursing do publish admission spots, but there is a criteria because nursing is a science. You have to pass certain subjects and meet certain criteria for you to be able to study nursing.
Our high school, our secondary school education is the worst, I think. It's just terrible. So I can see how they cannot always get the people they need. Now I'm just curious, looking at HIV is a problem, I think, in all of Southern Africa. And I'm just wondering if other countries are doing better or worse
Yeah.
than us. Do you know anything?
In epidemiology, we differentiate these things. So there is a term we call incidence. So incidence is like the proportion of the population that is acquiring new infections. And then prevalence is the cumulative number of people who have the disease. So those two are different. So incidence tells you how widely or how quickly the disease is spreading. But prevalence tells you the burden, like how the gravity of the situation on the ground, how many people have been affected by this. So in terms of incidence, we had for a very long time one of the fastest HIV incidents in the
region.
sub-Saharan region. Yeah, and then in prevalence, we also had a high prevalence of HIV for some time. But now what we are seeing is that once we started this treatment, because one of the things that also affect prevalence that people don't report on is that it's not a bad statistic as such. It's a good statistic because it's saying that people who are contracting HIV are not being allowed to die off. They are being cared for, so they are surviving. And one of the things that can reduce prevalence is if people die. If people who have the disease die off, then the prevalence rate is going to go down. So it also means, prevalence is high, but it's not always a bad statistic to have a high prevalence of a disease.
I've
So you have to look at
I've
the
never had
balance
anybody
between,
explain it like that.
yeah, because you're speaking to an epidemiologist.
Yeah, now I know. Yeah.
Yeah, so the contributors to prevalence are new infections and people surviving. So ordinarily, what reduces the prevalence is deaths. People die off. Or if you cut down the number of new infections that are being reported. So our prevalence has been very high, and I'm not really concerned about it because I'm from the system. I know it's because we are keeping HIV positive people alive for much longer than other countries because we are providing free access to antiretroviral therapy. So it's a good statistic from that perspective.
Yeah.
And then the one that is worrying is the incidence. So our incidence rates, like the rate of new infections, is also still a little bit high. It needs to be brought down much, much more significantly. And there are interventions that are in place that are aimed at doing that. So those don't seem to really be working.
But I remember, Uganda having the worst of it before, I mean, round about the same time when it was really bad for Botswana. But it doesn't look like they're in the same sustained crisis mode that like we are. What's going on with that?
What had happened in Uganda is I think their primary healthcare system was much, much better because they instituted some policies that were really effective in preventing HIV care. You have to also note that in Uganda, the culture is a little bit different from our culture. Marriage rates, for instance, in Uganda are very high, So marriage rates, people marry very, very early, and the public healthcare system is primary healthcare based. So prevention is really taken very, very highly than it is in our country.
Why do you think that is? Why are people not doing anything to prevent getting infected?
In Botswana?
Botswana, yeah.
Well, I mean, there's I think there are more issues because once you talk about people's reluctance to engage in preventive activities, it's now you're opening a can of worms because it's multifaceted. There are so many reasons. I think what we need to recognize is that
We
the
got
social determinants of health.
mm,
So those circumstances that people find themselves in that they don't really have much control over
mm,
because of the society in which they grow up. Those are the social determinants of health.
mm.
So HIV is intertwined in these social determinants of health. You have to recognize our country is one of the most unequal countries in the world. So there are people who have the people who have it going for them. They do have it really going well for them.
Yeah, for
And
sure.
then you have another large sector of the society that is really in poverty. They are really poor and they
Yeah,
don't have anything going for them.
yeah.
You don't really need to do much. Just go to G West. Just in the evening, just go and stand in G West. And then you will see the social determinants of health
Yeah, yeah.
at play. They will just it just plays out for you. So yeah, so and then when you start to have conversations with these people, because these are our
Yeah.
people. When you
Human.
start to have conversations with them, then you really understand that the actual interventions that are going to bring this thing down are much, much higher than of health inequity.
Mm.
So,
Okay.
and
What?
stigma also contributed to people not engaging in preventive care, like people
How?
who are
How?
taking.
What's
I mean, now there is treatment. Like I was saying, to prevent HIV, you have to treat HIV. So
mm,
now we are talking about PrEP,
mm.
pre-exposure prophylaxis.
Yeah.
We can actually put you on treatment before you acquire HIV because before you get infected with HIV.
Mm,
But the way we do it is we look at, are you at high risk or do you believe that you are at high risk of being infected with HIV? And then we'll put you on treatment to try to reduce the risk for you to getting HIV.
and
But
yeah,
people, because the same drugs that we are using are the same drugs that are being used to treat HIV.
doesn't the medication have any long-term effect, even if it prevents HIV? Is it not going to harm them in the long
All
run?
medication, all medications have some kind of side effects.
Yeah.
So, but you have to balance the benefits with the risks.
Mm,
The current medications that we are using, they don't really have much documented severe side effects. So people are making that decision to say, okay, I would much rather have this drug that is relatively tolerable
mm.
compared to the risk of acquiring HIV.
But
So
even though a condom would have been a lot better and cheaper and
yeah, yes, a condom would have been a lot better and a lot cheaper. But then we have to square this with the fact that the rate of alcohol consumption in our country
Mhm.
is so high. And so once you go out, you have alcohol to a point where you can't make rational decisions about sex.
Mm,
You are not likely to use protection.
mm,
So if you had something that you already took before you went out to drink
mm.
to
Yeah,
protect you in case you make
yeah.
that mistake.
Okay.
So alcoholism, like alcohol consumption, is also one of the things that is driving HIV in
Why are
our
we
country.
pretending like we don't know these things in Botswana?
Well, we do know. I don't know why we pretend like we don't know, but we do know. And we are also a democratic country. We are also a free society. I mean, what would you do?
Okay. So what do you hope happens next with, HIV care in Botswana?
Um, I think our infrastructure is there, and I'm happy we have one of the best HIV infrastructure in Africa.
Mm,
What we need to do now is, if we are really serious about curbing the HIV pandemic, we need to address the social determinants of health. We
mm,
really need to address the social determinants of health, and that is going to take us industrializing. That is going to take us creating more employment opportunities for the youth, because HIV is really skyrocketing amongst the youth,
that's so
and
sad. That's so sad to hear.
yeah, that is sad. And then our education system is gonna have to be targeted at these important topics. And then our traditions, we also have to challenge our traditions, and we have to enhance the parts of our culture that are actually protective. So
Yeah,
it's a whole
I
sea
think the
of change
majority of
that needs to
Botswana's
happen.
problems stem from these social ills, and that most of them are social because for a woman
Yeah.
to end up becoming a prostitute,
Hmm.
I'm so sure that it has some social element to it because a woman who has the same exact qualification as a male counterpart, a
Mm.
guy stands a better chance of getting employment even though he has the same qualification as a woman. You know what I'm saying?
As a woman.
So they're all
Yeah.
because of our culture is so patriarchal that people don't
Yeah.
even know that that's what's at play. And when we
Yeah.
try to talk about it as women, people think
Hmm.
that we are a mambasadi or whatever. That's
Yeah.
where the problems are happening. For instance, if if you have children, a male and a female
Hmm.
from two different, let me just say, two different tribes, okay? And they're
Hmm.
both firstborns of their fathers, the
Yeah.
whole tribe is going to favor the male to be, and that means a girl can go without employment. You know
Yeah.
what I'm saying? Whereas the guy
Yeah.
is sure that he's going to get that job. Even in the army,
Hmm.
I'm not trying to say women should be given things just because. All I'm saying is even if you have the same qualification as a male counterpart, he's going to be
Yeah.
paid before anybody can ever consider a woman.
Yeah. And the sad part about that statement is that most of the time you'll find that this woman is actually taking care of more babies.
Yes.
So he has more dependence than the male part,
Yeah.
the
Yeah.
male competitor. So if we disadvantage this woman who has 10 other dependents on her, and we favor this gentleman who sometimes doesn't even have a dependent, is himself a dependent.
Yeah. 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 That's why they end
So
up abusing
it
alcohol a lot,
becomes it just
and
keeps on.
yeah, it's just a
Yeah,
vicious
they go
cycle of
have
our
alcohol, and then
society,
because they have more
unfortunately.
resources, they end up
Yeah.
they have more resources than these girls, and we can end up just have deciding,
Yeah.
uh, I have to get this lady because I can afford to. So
Anyway,
it's
yeah.
that needs to be balanced, but it's going to take policy and strategy to do it. But I think we have been making progress in that regard, looking at the number of females that have achieved, like, leadership roles. But
No, those are just tokens.
what I'm lacking is the commitment of females who are achieving leadership roles in, balancing the society, you know,
My biggest theory is that when a woman makes it to the top, she becomes one of the guys. She stops
becomes
being,
anti-woman.
she stops becoming a woman. But anyway, are there any breakthroughs? Because we don't get to hear this kind of information. So are there any
Yeah.
breakthroughs that we should be proud of in this HIV AIDS battle from Botswana?
Yeah, definitely. Definitely. I know there are some researchers in Botswana who are doing cure research.
Hmm.
So I think you are talking about cure, but there are some researchers in Botswana at Botswana Harvard
Hmm.
AIDS Partnership that are doing cure research. If you speak to Catherine Kufetlile, she's a scientist.
Or you can get me her contacts.
Yeah, Botswana Harvard. Yeah,
Okay.
yeah, I'll give you her contact. They recently had a breakthrough in South Africa where they were able to keep children suppressed even though they were not taking treatment. They have some immunology technology and science that they are using to do that, and it's showing promise.
Mm.
I think she'll be the best person to talk about that. I'm not doing that kind of research for now, but we do have something that I have planned with her.
Okay, so what
Yeah.
other studies are you working on in the pipeline, so that
Yeah. So well, right now I'm looking. I have a study that I'm doing for my PhD. I'm looking at tuberculosis.
mm,
So TB is a problem. We are one of the countries that is reporting high rates of TB, and I think what I'm looking at right now is the severity of TB, because severity of TB is an important trait that people are often under, but severity of TB. So how severe the TB disease that you have is. It's an important trait that is understudied, severely understudied.
Mm.
And however, we know that how severe the disease, the TB disease that you have has implications on your ability to transmit the bacteria to the second person. It also influences whether you do well on treatment or you don't do well on treatment. It also influences your risk of dying from TB. And people are dying even though they are being treated for TB. Even though TB is curable, people are still dying from TB. And then there's also long-term effects of TB, like post-tuberculous lung disease, where you have literally reduced or cured. So that's what I'm studying. So I'm also studying the relationship um, between different measures of this severity. Like if I look at your chest X-ray and say this TB is severe, is it the same as someone using a different measure in a resource-limited country where they cannot get the chest X-ray? There's
Mm.
another score that is used, looking to see whether these things are actually measuring the same thing, or
Mm.
they are just measuring different domains of the same context.
So,
So
Lent, now,
yeah,
are you lost to Botswana? Like, are you just going to be an international researcher? I mean, so this research that you did, does the Ministry of Health know about it?
yeah. I mean, I did this study while I was still in UPenn,
Mm.
in
Mhm.
Botswana.
Mhm.
So obviously, for me to do this kind of research, I have to propose it. And I proposed it to Ministry of Health. They looked at it and they judged it to be a safe study and important study, so they approved it. And I was doing it in facilities that are in Botswana.
Mm.
So I have communicated my findings to the relevant departments. I've shared my manuscript with them. So after that, as a researcher, that's all I can do. And I've made myself available to say, if you need me, I'm here. If you need anything, to explain anything, I'm here.
Did
And
you
I've
get
not
that
heard
call?
anything. No.
Which means it's just
So
gathering dust.
yeah, well,
Were there
it's going to.
any specific recommendations that you really wish could be pushed from your study or?
Yeah, one of like you alluded to earlier on about missed clinic appointments.
Mm.
The effect of this variable of missed clinic appointments was so strong that even after controlling for other variables, this variable was saying, I am here, I am independent, and I'm having this effect independent of any other
Mm.
variable that you have measured. So
Mm.
it was so strong that I felt like, you know, in terms of clinical implication, as a doctor or as a nurse sitting in my clinic, whenever I have a patient missing a clinic appointment, that should worry me because the study is saying this is a patient who's going to fail treatment, and this is a
Mm.
patient who is going to get lost to care.
Mm.
And you can't be losing people who are on treatment from care. And you can have people who are on treatment failing infections. So it has preventive implications. It also have clinical management implications. So I was hoping they could say, okay, let us now commission a study to find out the context within which this that is causing people to, just disappear from care, and how can we address it,
Mm.
you know? So that's something. In terms of the infrastructure, I think the infrastructure is okay. I'm hoping that more will be put to keep people who are on treatment, maintain them on treatment, so that we don't have a high attrition rates. We're experiencing higher attrition rates, even though compared to the last strategy, it wasn't bad. There was a point where we had 42% versus 30 something. So 42% of patients being lost to treatment. It's a very high attrition rate. But then we have to know, where did these people go? Are they back into the medical system somewhere else, or what?
Mm. So now,
Yeah,
what did you say about the number of, nursing staff in Botswana? Are you,
yeah. Losing. Unfortunately, the country is losing. We spend so much money training nurses in Botswana, and then we employ them, and then we underpay them. We don't reward them, and then we don't treat them well, and then we lose them to the developed world because there are better opportunities there. So if I can tell you how many people that I have seen just on social media that have gone to the UK, and I know that these are people that I trained myself. I trained them, and I know these people were uh, like some of the best HIV clinicians that you will find in our healthcare system. And I just looking at them on the social media. They're in UK, they're in Ireland, and they are everywhere else. And the Botswana never used to like traveling. They
I know.
never used to like migrating, but
Mm.
it's because of the economic situations. Their economic situations and their employment conditions of service that are driving them to just, it's better to go and work somewhere else where you get better rewarded for your efforts. So
No,
people are
that's
leaving, and that
heartbreaking,
is sad.
actually. I'm listening
That
to
is
you
heartbreaking.
and I'm just sad because I know exactly what you're talking about. And one thing that I think our country, our government used to be so paternalistic
It is.
that we all became dependent
It
of the
is
state.
heartbreaking.
So yeah,
Mm,
we used to be dependents of the state, and the government of Botswana used to actually be a
mm,
real tangible. It used to be a real tangible entity where
mhm,
it was very centralized, and so that thing I think it has
mm.
completely broken down, where we just have a skeleton of a former system that we used to have. Never mind the political stuff that we have a new government,
Yeah.
but it's like the people
Mm,
who are the decision makers, policy makers, everybody, what if those people don't even exist?
mm.
It's like people are just
Yeah.
there for the positions and the benefits and the remuneration. Nobody really cares about anything anymore. One of the issues
Oh
that I,
no, that
yeah,
that one is,
go
yeah, that one is a problem. It was and it's not only a problem for you. It usually is a problem for people who are really driven to bring change.
on.
Um, because we go into the system and then we fight the system and the system fights back.
Mm,
And eventually you just feel like, well, I'm really out of place here. I'm at a place where I'm not supposed to be. Um, I'll give you an example. When I came to the US to pursue my MSce in epidemiology, I was still an employee of the Ministry of Health. And when I completed my MSce, I came back because I knew there's a problem of people coming to school and then not going back to serve their country. I completed my MSc here. I had offers. I could have stayed here, but I decided to go back. And guess what? I went there. I was like, okay, look, I have done this advanced training at tremendous expenses at one of the best universities in the world. And can I at least have responsibilities that are aligned with my training, my
mm.
recent training? And I didn't get that. They just tell me, go to the clinic. Just
I
go to the clinic.
know. I'm a victim of
Yeah.
something
Yeah,
similar.
so I went, so now I was confronted with a choice. Do I want to be someone who has just, undergone this intensive training for 2 years, acquiring these skills, and then go back and let them just rot? Or do I want to grow my career in that direction?
Mm.
And it was clear that that aspiration to grow my career into that direction is not going to be seated in the Ministry of Health.
Oh, yeah.
So I ended up leaving because not because I wanted to leave, but because there was no opportunities.
Botswana is where all the dreams come to die.
Yes, exactly.
If the
So
government of
now,
Botswana takes you on training anywhere else in the world, and
Mm,
you come back, it's like you're just coming home to die. They don't care. I remember when I finished my my school a long time ago, I came back and I
mm.
used to call the ministry, where do we start paying? Because I had a nice paying job and I used to beg them to pay back my what do you call it? My scholarship fees.
Hey.
No, they didn't have anything in place. They didn't care.
That's the
It's
thing
sort of
that's just
Botswana.
it's just so surprising because I mean if you have an officer leaving your department and they are going for training for 2 years, they are away for 2 years training. And when they come back after 2 years, you have no idea how you are going to utilize the skills they have achieved. It's just incompetence.
Yeah, no,
It's,
no.
it's
Our
lack of
our system
direction.
our system is just so broken, and it's very heartbreaking.
It's really heartbreaking.
Do you
So it's
anyway? I don't want to
It's
drag you
just
into
heartbreaking.
politics.
And I know there are people who have similar stories as mine, and I didn't want to just go there and rot. And there are people who are patient and very patient. I'm not one of those. If
Good
I
for
was
you.
in the system, they know that I was in the system and I fight.
I
I
remember some
fight.
years ago,
Mm,
I decided to go. I lived next to a government clinic, and I decided to just go there. I'm like, I'm a citizen of this country, and I've been paying tax for so
hmm.
long. Let me, and the clinic every time is just by my house. I see that there's not a
Yeah,
lot of movement, and I'm like, maybe
yeah,
I can get something. So I started
yeah.
attending
Just
that clinic, and there was a young foreign doctor. I'll say she was foreign because she didn't speak Setswana. She was a young lady.
mm,
And
mm,
I just started talking to her because I like knowing what's happening in Botswana. And I found
yeah.
out that she said, no, do you know what? I'm not even supposed to be here. They have not renewed my contract or my permit or whatever.
Just imagine.
But because she's a nice person, she decided to come to the clinic to help. But I don't
Yeah,
know whether she was getting paid or not. Good, that's how bad things are in Botswana. And there's all
yeah,
this money thrown in to train people to try to no good, there's no coordination of anything. Why
yeah.
there's the department of this, the ministry of that, but there is absolutely no cohesion in the system.
Yeah, at the center of all of this is bad recruitment.
Hmm.
It's recruitment that is not meritorious. It's
Oh
not
yeah.
merit-based.
Hmm.
It's just you have connections and then you get people that are connected to you socially or otherwise, and corruptly and through nepotism, you put them in positions. They are not prepared for these positions and they don't know what to do. They are not even confident of making decisions because they landed there by mistake.
Yeah.
So they
No.
are not there by merit and they're so afraid to make mistakes. They don't want to make decisions that are autonomous. They have always have to wait for their boss' approval to make even the simple decisions you know
Yeah.
so it's a that system had gone on for a very long time, and the public health sector has been contaminated by these people. And the new administration has to be serious. If
Mm.
they want to deal with the problems of the country, they can't do it using the same people in the
People.
same
Yeah.
positions.
And one of the things that really break my heart is that I had
Mm,
the unfortunate misfortune of giving birth in a government hospital some 25 years ago.
mm,
And it was because I had recently gotten married. And so I was out of the waiting period for the medical aid out by 1 month. So I had no choice. I
mm.
had to go to a government hospital.
Yeah.
Orland, that place was filthy. There was no care. It was just horrendous. During COVID,
It's just- mm,
I'm talking about the year 2000. During COVID,
yeah.
my sister gave birth to a premature baby. The baby
Mm,
is wonderful. She's thriving as we speak, 3 years old. And
mm.
she still went through the horrors that I experienced 20 years earlier, 22 years earlier.
Oh, God.
Nothing changes in this country. Where
Yeah.
she said one
That's sad.
time, because she had a premature baby, the place where they keep all the babies, she says sometimes when you come in, you find two
Mm.
babies both on the side of your baby having died in the night. And you just have to go there and handle your child and that two dead babies on the side.
Oh my God.
What is that?
That's that's BS. Oh,
Yeah.
sorry.
Yeah. No, no, it's fine. You didn't say anything bad. You said the truth. So
Sorry.
anyway, right.
Yeah.
It's been a pleasure
Yeah.
talking to you. I
Yeah.
just hope that the information that you shared today can help us move,
Mm,
move, get ahead in Botswana.
mm,
So I'll
mm.
just give you the last 2 minutes to wrap up and say your last words.
Yeah, I mean, what can we say? Thank you for giving us the platform to discuss. Hopefully, next time we'll discuss issues of integration and the healthcare system. I think I'm still available for now, and I have plans to do research in Botswana. There are other areas that I'm interested in. Um, yeah, hopefully we'll have impact. But I mean, I'm a person. I have needs. And when I complete here, I'll see what is on my table. And yeah, so I mean, people in Botswana know me, they know about me. The people I've worked with, some of them are in the ministry, and I'm putting myself out there. When they ask for people, I do apply sometimes. Sometimes I just look at it as like, yeah, well, whatever.
Mm,
So, but for now, I'm here. Fortunately, I made candidates, so it's really within reach that I may complete
mm.
and come back, hopefully come back to Botswana and do cutting edge research.
Yeah.
But I hope the research is not going to have any impact, like what value is biomedical research if it's just going to sit on the table and gather dust and we don't use the findings?
Mm,
you know this is not really going to be impactful.
mm,
So research has to be actionable. If my research tells you you need to pay attention to missed treatments visits, then you have to do that. you know if you don't, then you have been warned, you've been told the truth, and there's nothing I can do. As a researcher, I have to go out, find where the truth is, what is the circumstance, present it. I'm not a policy person. Someone in policy should call me and say, okay, I have read your study. What policy changes can I do? What are you recommending? And I'm like, yeah, this is what I found. And I don't know what policy you can do to address this. So
mm.
that's as far as I can do.
Okay. But so I was
Yeah.
gonna say one last thing.
Mm.
How many clinical what's the term again? Your title?
Epide- epidemiologist.
Yeah, how many are there in Botswana, like local people?
I don't know how many are they. I just know that I'll be the first one trained at PhD level.
Wow, you've got a good
Yeah,
thing going. Keep in touch. Next
yeah,
time we're going to talk about regional integration and health in Botswana. Okay?
yes,
Thank you so
yes.
very much. This has been
Okay,
so
Mira.
insightful. I think
Yeah,
Botswana have a HIV fatigue as well, where there's so
yeah,
much information and but they don't understand that the problem is not going away. So we really need to keep
it's
this
not.
conversation in
Yeah,
the front and not in the back burner. So
that is so true. Yeah,
thank you so very much, Lent.
yeah. So you're
Talk
welcome.
to you soon.